Welcome to our webinar, Ocular GVHD, Diagnosis and Treatment. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you're unable to view the program online, you can call in to hear the audio portion using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type in your question or comment in the small text box window. And when you have finished typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Today's specialist is Dr. Sandeep Jain. Dr. Jain is a director of the Dry Eye and Ocular Graft-versus-Host Disease Services in the Department of Ophthalmology at UI Health. He specializes in cornea and refractive surgery, corneal wound healing, dry eye disease, and ocular GVHD. He also directs the Translational Biology Laboratory in the department. After receiving his medical degree, he joined the Wilmer Ophthalmology Institute at Johns Hopkins University as a pre-resident fellow and completed his residency training in ophthalmology at the Harkness Eye Institute at Columbia University, New York, followed by a subspecialty in corneal diseases at the Massachusetts Eye and Ear Infirmary, Harvard Medical School. His clinical and translational research work has led to numerous publications in professional journals, as well as the development of drugs that are in phase 1 and 2 clinical trials. With that said, it is my extreme pleasure to welcome Dr. Jain.
Thank you, Lee. I thank the Aplastic Anemia and MDS International Foundation for providing me with the platform and this opportunity to talk to everyone today regarding something that I'm very passionate about, a topic that I think in the past decade or so was overlooked, IGVHD, the way the ocular surface, the eye surface, gets involved in graft versus host disease that follows bone marrow transplant. This is something that I think, like I said, was frequently bunched together with dry eye disease up until recently, and probably the practice still goes on. To the detriment and to the of our patients who we serve. And I'll highlight some of that as we move forwards, that that conceptually it is so important to think of dry eye disease and IGVHD as 2 distinct and separate entities. That IGVHD is an entity in of itself, and that causes a great amount of morbidity, trouble, misery to patients who get bone marrow transplant. And until and unless we appreciate that and understand that, I think we would be taking just baby steps in in helping our patients. So that introduction was about IGVHD, and it's the introduction that I like to give before I start speaking, because I think this is the most important message, is to understand the disease as its own entity. Thank you, Leah, regarding for giving such a wonderful introduction about me. But I feel compelled to tell everyone that an individual, no matter how much you know about GVHD or IGVHD, cannot make a difference without a team that is of individuals who are dedicated to taking care of patients with IGVHD. And at UIC, we have a dry eye and ocular GVHD clinic, which is really not a clinic, but an ecosystem of sorts, where there are so many wonderful individuals, clinical coordinators, research coordinators who take care of the patients with IGVHD, who collaborate with our compounding pharmacy, which makes possible all the treatments that we give to our patients. Our contact lens service, which dispenses all kinds of contact lens fittings and interventions for our patients. Our fellow surgeons, whether it's cataract surgeons who specialize in surgeries on GVHD, on patients with who have suffered GVHD on their eyes, whether it's cataract surgeries or corneal surgeries or oculoplastics. These are all very important, because without this, we cannot make the kind of difference that we try to make in the lives of our patients. So that was a very long introduction for the first slide, because I have 45 minutes in this presentation. And so I'm going to go at a very leisurely pace. Let's talk about IGVHD first, what it is. And then I'll go into how we diagnose IGVHD. I'm going to call it IGVHD just to keep it simple. Although the technical term might be ocular GVHD, just feels a little bit more scientific and medical if we call it ocular GVHD or GVHD. So then we'll talk about diagnosis and look at how patients present with this condition, and then we'll talk about the treatments, and hopefully I'll digress along the way into various directions. So IGVHD is a very common manifestation of chronic graft versus host disease that happens after bone marrow transplant. In some cases, we say that it happens in 50%. It happens 50% of the times after a allogenic hematopoietic stem cell transplant or bone marrow transplant. That's a very frequent complication then, and it is one of the most common problems that happens after bone marrow transplant. When does it happen? Well, we have seen that the risk period really starts about 6 months after bone marrow transplant and extends to about 2 years thereafter. That's the time when the eyes can act up. And they typically present as a red irritated eye. Many things happen, we'll go over them. But essentially, the two main problems that I'm most impressed by are the misery, the symptoms it causes the patients to perceive, the eye discomfort that the disease can cause. And I hear sometimes our patients describe it in very graphic fashion. It's one of the things that stuck with me was a description from someone who said that the eyes feel like they have been dipped in hot sauce and rolled in sand, and that's how it feels like every day. And that's something really terrible to happen to anyone, to be suffering with this sort of misery, this sort of discomfort. And that is something that goes unappreciated or underappreciated by physicians, that this is a condition that needs to be taken seriously. The other thing that happens is vision, that the vision becomes blurry. You're not able to do the things that that one is wants to do, and that's very disorienting. Also, is that not only do the eyes feel uncomfortable, you don't see as well too, and that really both these things impact the quality of life substantially, such that a lot of my patients, they are almost as if they want to go on disability, or they don't want to do anything. Their useful, productive work is being impacted. Their socialization, relationships with others gets impacted. So I understand, and I see that happen every day, of how this condition can take over someone's life, really. And so is the motivation for us to try and help and make a difference. And here I have realized that we cannot do that without our team. Yes, I spoke about it, but also without an active participation of our patients, who are actually do the hard work. It's very easy for me to tell them to take eye drops, many different kinds, along a schedule, but they have to do the hard work. They have to do it every single day. And that's what really makes a difference, is this collaboration of sorts between our patients and us and our team, that makes for outcomes that that we see viable. So I told you that I'm going to talk about diagnosis first. This is a eye of a patient with IGVHD, and you can see that this eye is pretty red, irritated. The eyelid margin has these vessels that are coursing all across them, and this patient had a terrible IGVHD, and that's how the eyes typically look: red, irritated, mucus coming out of them, and they cause there's light sensitivity, discomfort. That's how a patient comes into my clinic. So what do I do first? We have to diagnose the condition. The IGVHD or ocular GVHD is a clinical diagnosis. There is no test such as for diabetes, we do blood sugar test. While if the hemoglobin A1C is up or down, we can make management changes or treatment decisions. That's not the case with IGVHD. There is no single test that is there that can, if abnormal, can tell you whether you have IGVHD or not. So the diagnosis is primarily clinical. And I was part of this committee, that consensus group that came up with this diagnostic classification of how one would diagnose a patient as having IGVHD. And there are a couple of, so we said, fine, let's make it simple and rely on 4 easily available clinical tests that every ophthalmologist does. The first test is to just ask the patient about how much they are suffering, using a questionnaire. And based on that questionnaire, we can get some scores, and that is just a number on a patient's misery or symptoms, and that is called Ocular Symptom Disease Index, or OSDI questionnaire. And based on that question, the answers a patient provides, we can get a score, and that's one data point that is relied upon to make the diagnosis. So the first thing in making a diagnosis of IGVHD is to to figure out how much is the patient suffering because of the eye problems. That's number one. The second thing that we want to know is whether the patient is producing tears or not, whether the tear production ability of the patient has been compromised. And we can do that by performing a test using a filter paper that we place over the surface of the eye. And over 5 minutes, depending on how much tears the filter paper is being wetted, we can figure out whether tears are being produced or not produced. And that's the second data point that we rely on. So the first is how much the patient is suffering because of the disease. How symptomatic is the patient? Second, whether there is ability to produce tears or not. The third thing that we see is how red the eye is. Why? Because generally, if there is inflammation, there is redness. So there is a correlation. So if the eye is very red, one can deduce that it might be very inflamed. So that's the third data point that we look at. How red is the eye? So we want to know how much the patient is suffering, how much tears the patient is producing, how much red is the eye. That's the third one. Then we go to the fourth data point, which is a clinical test where we put a dye over the eye surface, and then we see how much that dye stains the surface of the eye, which tells us how diseased the surface cells are. Because if the cells are healthy, they will not pick up the dye. If they are diseased, they will pick up the dye. So fourth data point that we rely on is how much the surface cells are, what is the extent of their disease, and that we can do by putting a dye on the surface of the eye. So these are the four things that we are interested in while we try to make a diagnosis of IGVHD. How much are you suffering, whether you can produce tears or not, how red is the eye, how much the surface cells of the eye are diseased. When we have this information, we want to know whether the person has had other organs involved with GVHD. That means that do they have chronic GVHD already diagnosed? And if yes, the threshold of making a diagnosis of IGVHD is lower. But if they have not had GVHD anywhere else, that threshold is a little bit higher. We tally all the points, and then based on the number of points a person gets from the four things that I talked about, we can make either a diagnosis of definite GVHD or say that patient does not have GVHD, and there is a gray area in between where it's iffy whether or not you have GVHD or not, but it is going towards GVHD. So that is the way in which we make the diagnosis. And I'll go a little bit more on the kind of questions that we ask in trying to figure out whether the patient is suffering. This is the questionnaire I was talking about, Ocular Surface Disease Index. And we basically ask questions and we say, well, in the past 1 week, can you tell us whether your eyes were sensitive to light? And the answer could be yes or no. And if the answer is no, one gives us get a 0 score. But if the answer is yes, then we further qualify to see how persistent the symptom was by asking if the sensitivity to light was some of the time, half of the time, most of the time, or all of the time. So those are the kind of questions we ask, and those are the kind of responses that we collect. How were your eyes sensitive to light in the past week? Did your eyes feel gritty in the past week? Were your eyes painful or sore in the past week? Did you have blurred vision or poor vision in the past week? That tells us about what the discomfort level was in the eye. Then we also are interested in knowing how the eyes are affecting you. Uh, so the kind of questions we ask is, in the past week, uh, have problems with your eyes limited you in performing reading, for example, or driving at night? Or can you drive at night or not? Or watching TV or working with a computer? And then we are also interested in knowing whether the eyes feel uncomfortable in environmental stress, like if it's windy outside, then do the eyes become more uncomfortable? And the answer could be yes or no. And all of this goes to tell us whether GVHD has started to act on the eyes. And I can tell you this, that we have done a lot of work on using these questionnaires to figure out if someone is at a high risk of developing GVHD. And we have the answer to that question now, that if the score increases by 10 or so from pre-transplant levels, that a person is at a very high risk of developing IGVHD. So yes, these questionnaires help. Then the second thing that I told you was that we look at ability to produce tears. And this is the way a Schirmer strip or a filter paper strip is placed on the eye. The eye is gently closed. This is done without anesthesia. And you can see the wetting over here. So this person is producing enough tears. And if the wetting is not seen, then the ability to produce tears is lost. And that is indicative of IGVHD. These are some examples of dyes that we use. Fluorescein dye, which is a yellow dye. And what it does is it stains the diseased cells. When we look in a fluorescent light of slit lamp, we see them as yellowish dots. And each of those dots is actually a diseased cell that has allowed the fluorescein dye to go inside it. Normally, they don't allow the dye. Healthy cells do not allow the dye to go inside them. But if the surface cell its membrane has been compromised by dryness or by inflammation, then the dye can go inside, and I can see it with the slit lamp as a yellow dot. So the more the number of yellow dots, the more severe the disease. Normally, I should not see a single yellow dot on the surface with the dye, but in GVHD patients, see how much we can see. This patient has a lot of dryness and disease on the surface. There's another dye that is called lissamine green dye that we use to look at the dryness on the whites of the eye, on the conjunctiva. And again, the principle is the same. Normally, the dye does not enter healthy cells, but if the cells are diseased, then it goes inside the cell, and I can see them as dots. In this case, as a blue dot. So there are various ways to figure out whether the surface has the disease or not, and to record it on the chart. This is another example of a patient who has very severe surface disease. The cells of the surface are damaged due to dryness or inflammation, and I know this. And I know this why? Because on this surface, on this eye, I had placed fluorescein, and the fluorescein had entered the cells. And I see these dots. See these dots? Each of these dots is a diseased cell. And there are plenty. The whole cornea, the transparent front part of the eye through which the light passes, the whole surface is diseased, and the cells are picking up the dye. And this eye has extensive disease. Now, the same eye that I showed you, if I use a different dye, lissamine green, confirms the fact that this eye has cells that are diseased. Each of these dots is a cell in which lissamine green dye has entered, and each of these cells is diseased, is by inflammation or dryness. So this particular patient has extensive surface disease. And that's how I know that this person has extensive surface disease, because the dye that I placed on the eye entered the cells and shows up as dots that I see with the slit lamp. I talked about eye redness, and this patient has a lot of eye redness. I mean, these are pictures that we use to grade patients who have eye redness. It's not a very good picture, but at least you can know that this person over here, the picture shows very red, white redness on the white of the eye versus compared to this picture. And the more the redness, the greater the score. And in these patients, in GVHD patients, we see a lot of redness. Redness equals inflammation. So if the eye is red, I'm thinking this eye is inflamed. And also these eyes have mucus discharge that comes in if they are inflamed. So if a patient says my eyes are red and there is mucus-like discharge coming in, I'm thinking this patient has severe eye surface inflammation. This is how we make the grading for diagnosis. In this hypothetical patient, this patient was not able to produce tears, so the Schirmer tear wetting of filter paper was less than 5 millimeters in 5 minutes, and so we gave it a score of 3. This patient had the cornea filled with yellow dots on fluorescein staining, so we marked it as having very high level of surface disease. The patient was giving us moderate symptoms of dry eye and had eye redness. And when we calculated the total score, it turned out to be more than 8. And so we made the diagnosis of eye GVHD in this patient. It's a hypothetical patient, but we can label this eye as having definite eye GVHD. So that's how we make the diagnosis. That was all clinical and relied upon my observations. There are some other things we can do, and we do routinely in my clinic, which is to use certain tests to confirm with what we just saw. If the eye is red and has mucus coming out of it, and I know that there could be inflammation, but it's helpful to prove to yourself and show it to the patient that actually that is true. And we do that with a test called MMP9 test or inflammadry test. And this is a protein, inflammatory protein that is there in the tears. What we use is a device such as this to pick up the tears from the surface of the eye from the lower lid. I evert the lower lid, pull the lower lid down, and use a handle with a swab at the end of it. And I dab on the surface of the lower lid, on the inner surface of the lower lid to pick the tears up. And then I test it in this device. And in this device, if a pink line develops on here, that means that inflammatory protein is present and there is inflammatory protein in the tears. That means the surface is inflamed. If I do not see a pink line, that means that the inflammatory protein was not picked up in the tears, and that person probably does not have surface inflammation. So it is good for me and important for me to know how strong this line is. If the pink line is very strong, tells me that the inflammation is very strong, and then I'm more aggressive in treatments than if I don't see the line to be very strong. And what kind of treatments would we give in this case? Well, if it is inflammation, obviously we will give anti-inflammatory treatments, and there are several that we'll talk about. But so how do we diagnose GVHD? We performed a clinical examination. We spoke to the patient about what was their extent of symptoms. We measured their tears. We looked at their eyes, whether they were red or not. We put some dyes on the surface to see whether the surface was diseased. And then we can perform this test to further confirm whether there is surface inflammation. Those are the ways in which we diagnose eye GVHD. But there are some things that the classification systems miss. A very important thing that we frequently miss is appreciation that the oil-producing glands that reside in our lids can be damaged by the chemotherapy that patients get prior to getting bone marrow transplant. That's one. Or the GVHD inflammation also causes them to atrophy. So these glands, these lines that you see over there, here, these whitish lines, serrated lines, these are meibomian glands or oil-producing glands that reside in our eyelids. In the upper eyelids, you can see them if you evert the upper eyelid. If you flip the upper eyelid, and if one was to flip the upper eyelid and look with the infrared light, this is what one would see, which are these glands will shine. So this is a eye of a patient, a normal healthy subject that I have flipped, and I'm looking at the inner surface of the eyelid with the infrared light, and I see these oil-producing glands, and they look normal. They're long lines of white that you see. That's how normal should look like. That's how normal should look like. And here. And when this is normal, I see numbers, how much oil there is on the surface of the eye. This is a machine that we have, and we do this test on all patients. We find that the oil thickness is about more than 70 nanometer, which is pretty thick. And here it is thick enough. Here it is about 100 plus. And so this person has normal glands and normal thickness of oil on the surface of the eye, which is what we want to see. Now, what happens to a patient with ocular GVHD? Now, this patient may have had chemotherapy before bone marrow transplant. So I wouldn't say for sure that this is a problem that happened, that GVHD has done that. Well, maybe chemotherapy has done that before they actually got bone marrow transplant. But GVHD can also do that. But regardless of who we put the blame on, what happens is that these lines, which signify intact glands, they disappear, they atrophy. There are no glands here in the upper lid. There are very few truncated glands. A lot of them are lost. A lot of them are in the process of being lost. So these glands are lost in IGVHD, and they're very important glands because they are needed to produce the oil, which prevents the tears on the surface of the eye from evaporating. And if these glands are lost, a severe dry eye can result, and that's what is happening in GVHD patients. So how do I know that they're not producing oils? I look at this number. How thick is the oil layer? In this patient, 22 nanometer. That's very low. That's almost non-existent. I told you that the normal is about 70. This is very low. That means that this patient is not producing oils that are so important for the health of the surface of the eye. And the surface is going to be very diseased because of lack of oil. And that's something, again, that goes unappreciated. So I'm going to be looking at the time every now and then to see how much time is left, and I'll have somebody here tell me how much time is left out of the remaining 45 minutes. Don't want to go over and eat into the question hour session, but at the same time, I would like to be cognizant of the time. So we talked about the oil glands. Now we'll shift to treatments in the next remaining time that I have. But I wanted to touch base on this question again first. And I think this is the most important part of the presentation. And I'm trying to change this concept from in the minds of physicians and the minds of patients, that IGVHD is not just another dry eye. And that is the single most important reason why patients suffer, diagnoses are delayed, the treatment failures happen, and we don't do such a good job. Because we think that this is just another dry eye, and we start treating it as just another dry eye by giving artificial tears or restasis or or just what one would do for any other dry eye, and which it is not. This is an immune injury to the surface of the eye because of bone marrow transplant, immune cells that is causing a subacute inflammatory condition that presents in many different fashions. It can cause fibrosis of the eye. This is fibrous tissue because of inflammation. We don't see that in dry eye disease. We see that in here in GVHD. There is this scarring on the upper surface, symblepharon formation, which is scarring. These are very diseased eyes that I'm showing you. This is all that all of this can happen in IGVHD. When the patients look down, there is a severe inflammation of under the upper eyelid that causes a lot of discomfort and pain that can happen. There is eyelid margin can get can show skin-like changes and keratinization, which is can cause more misery to the patient because of the discomfort it causes by rubbing against the eye. There could be epithelial defects that can happen that refuse to heal. And that's something that we need to know about. And because how can we heal them, that becomes a problem. Viruses can reactivate. And that's something that so it's very important that once a patient, if they have IGVHD and their eyes become irritated or red, you can't just think that it is just inflammatory. Sometimes herpes virus can get reactivated and it can cause a problem unless you treat it adequately. It's not going to heal, and that's so important. So any symptom that happens in these patients, we tell them that you need to go as soon as possible to your eye doctor so that they can take a look at the eye and start appropriate treatment. You cannot sit on it. A lot of bad things can happen in this condition, and the best way to help the eye and to have good outcomes is to be proactive, is to be aggressive about the treatments, is to go into your eye doctor. Any new symptom, you should call your eye doctor's office and tell them, don't wait for the next appointment. You need to tell them that this is a new thing is happening. Mucus has increased. The eyes have become more red, more irritated, so that they can see and make the appropriate diagnosis and treat. What's the best way to deal with treatments and diagnose? One should always have a pre-bone marrow transplant exam to establish a baseline, and then an examination every 3 months after the bone marrow transplant. But more importantly, anytime new symptoms happen, light sensitivity increases, redness increases, mucus discharge increases, you need to call your eye doctor's office and tell them about it, because you can't sit on it and wait for the next appointment. By that time, it may be too late. The inflammation may have knocked out all the oil-producing glands or all the tear-producing glands, or the disease, the surface of the eye, the surface cells could be damaged by then, or the fibrosis may happen by then. So now I'm going to talk about the treatments. How do we help the patients who have IGVHD? We use an aggressive step-down approach, which means that we focus on healing the surface disease and reducing the inflammation as soon as possible. There is no point in having inflammation linger for more than, it's already too long. We need to get it out as soon as possible. And we do that with several strategies. I'm going to go in no particular order, but the first and easiest strategy is to increase the moisture on the surface of the eye. We use preservative-free artificial tears, and there are many available on the market. But I was surprised to realize through my patients telling me that one of the most effective eye drops to moisturize the surface is actually normal saline drops that people use for inhalation. And I'll show you what I mean by that. And use that 4 or 6 times a day. That's very effective, more effective than much more expensive artificial tears, because it rinses the inflammation off the surface of the eye. We use erythromycin ointment at bedtime, a small dose of doxycycline for anti-inflammatory effect, contact lenses, and we use serum tears and steroid eye drops to control inflammation on the surface. Very important point that I would like to make here is that for all the eye drops, you should lay flat on your back, lie down on the bed, and then instill the eyes with the eye facing upwards so that the gravity is neutralized. There is no point in putting the eye drops sitting up or tilting the head back and then putting up. The gravity is just going to work against you. It's not going to be effective. Lay down on the bed, lay flat on your back, instill the drop, and gently lift the upper lid so a little bit goes behind the eyeball also. And then stay laying down for a minute or two. So eye drops instill, please, laying down so that the gravity has no role to play. No point getting the eye drops on the cheeks. Many different eye drops are available for moisturizing the surface. As I said, we use preservative-free saline, which is very effective. There are many eye drops that are available for treating dry eye, and you must have heard about Restasis, Cequa, Xiidra. They don't work as well in IGVHD for a variety of reasons, but that's the point I was making. You cannot assume that IGVHD is a dry eye, so all the treatments for dry eye disease will also work for IGVHD, and they don't. And that's something that one should remember. Compounded medications that we use are steroid eye drops and a host of other anti-inflammatory eye drops that we use. But the key issue is that they are all preservative-free. Steroid eye drops that you get from pharmacy are not preservative-free. They are preserved with benzalkonium, which is a harsh chemical. We can't put any harsh chemicals on the surface of patients who have IGVHD. And so our pharmacy compounds it, and we are lucky that they can do that and make preservative-free steroid eye drops. But if you have to use a commercial steroid eye drop, there are some that have very low benzalkonium amount in them, and you should ask your eye doctors to prescribe you eye drops that do not have the preservative. Oftentimes, a lot of our patients have glaucoma in addition to surface disease, and glaucoma. Ask your glaucoma doctors to give you eye drops that do not have preservatives. That is the mantra. No preservatives on the surface of the eye. Please ask them to give you treatments that do not have preservatives. We use a lot of our patients are on preservative-free serum tears. Why preservative-free serum tears? Because they have proteins in them. They have a lot of oil in them, lipids, cholesterol, which is so healthy for the surface of the eye, proteins, growth factors. It's a very nice rejuvenating therapy for the surface of the eye. And I think serum tears is an excellent therapy to help patients with IGVHD. We make them in our compounding pharmacy. This is how it looks, yellowish, pale yellow liquid. It comes from the blood. It's a very good strategy to heal the surface. Contact lenses, very important. We use soft contact lenses, which cover the area of the eye, not a whole wide area, but you can see that with the stain, the areas that are not covered with the contact lens, they still pick up the dye. The areas that were covered with the contact lens are so much healthier. There are bigger contact lenses, scleral contact lenses that we use, and they cover a bigger area, and so they can help even a little bit more. Moisture chamber glasses are very important, and they form a seal around the eye. Several companies sell them. Menards has one, which is very good safety glass. They are basically air shield eyeglasses. They prevent the wind from drying out the eye. A lot of online stores sell these. I think these are very helpful, and you should use them. Warm compresses with Bruder mask, they are very helpful. I think people should use them. We don't do much of punctal plugs and punctal cautery, although I know a lot of you have had them. Our philosophy is that if there is inflammation on the surface of the eye, you want to get rid of inflammation, not to lock them in with punctal plugs. There is a role for them in some situations. We feel that in the presence of active inflammation, as so happens with IGVHD, the role in the first year or two is little, and as long as the eye inflammation is active, we probably should not use them. So I would stop over there. I think it is 3:45 now at Chicago time, 4:45 by your time. And so I'm going to stop sharing my screen. I can always go to my slides again if needed and let the hosts of this meeting take over again. But I would very much like to answer your questions at this point.
Thank you so much for the wonderful presentation. We do have a few questions. Our first question is, what are the outcomes of cataract surgery on eyes that have ocular GVHD?
That's a very good question. And it almost seems like a setup question that I planted it, because we just did a whole study on it and presented the data at the American Academy of Ophthalmology. So cataract surgeries traditionally, if you perform in IGVHD, you'll see a lot of reports talking about complications, that there are epithelial defects that can happen, perforations that can happen. The results are not as good as in patients who do not have IGVHD. And that's conventionally, that's what you will see. And that should not happen. That's wrong. Should never happen. Why? Because we figured out that you need to control the inflammation and heal the surface of the eye before proceeding to cataract surgery. So IGVHD is fine. You can have that, and the inflammation is there. But control the inflammation with steroids, with serum tears, with artificial tears, with doxycycline, with whatever it takes to make the surface heal before proceeding to cataract surgery. And if you do that, then the outcomes are as good. I'll repeat that, as good as someone who has never had IGVHD or who's a healthy individual with no medical issues and is going for cataract surgery. So the outcomes that we have seen when the surface has been optimized, when they have taken care of, before the cataract surgery, taken care of the surface of the eye and made it heal, and then go for cataract surgery, that's the way to do it.
Thank you. Our next question is, will the scleral lenses help with blurry vision?
The scleral lenses can help with blurry vision, absolutely, several ways. One, they can help to heal the surface of the eye, which was the reason for the blurry vision in some cases. So that's one. Second is that we can put the prescription inside the scleral lenses, and they can help take care of the astigmatism and nearsightedness or farsightedness, whatever it might be, to help with vision. So I think there are several ways in which scleral lenses can help with vision. But these are the two main ones, which is to help the surface become smoother, the cornea, the surface of the eye, help that surface of the eye, the transparent part of the eye, which we call cornea, to become less diseased, so that optically it becomes a better transmitter of light. So a better image will be formed on the retina. That's crucial. And the second, to negate all the imperfections of the surface of the eye due to irregular astigmatism or whatever it may be, to give a crisp and a very good visual image on the surface on the retina. So yes, this is an extremely good way to help a patient see better. But what it will not help is cataract. If there's a cataract, you cannot help it. You need to get the cataract surgery, and then the scleral lens would help.
Thank you. Our next question is, how effective are your own serum tears if you have trouble with GVHD in other parts of your body, such as your skin, lungs, and liver?
That's a very good question. And I think This is a concern that is we hear frequently, not just from patients but from physicians, and for good reason. I think logically it makes sense, and not just for GVHD, for autoimmune diseases, for Sjogren's, rheumatoid arthritis. A lot of patients and physicians would say, well, if I have the disease, wouldn't I be doing more harm by putting those same things on the surface of my eye? Initially, I had the same thoughts. Over the years, I have realized after treating thousands of patients, that's not true, actually. Actually, it does benefit. There is no risk. So if a person has GVHD and we are using the serum of that patient on the surface of the eye, it does no harm. If the patient has rheumatoid arthritis or autoimmune disease, and we are using the serum of that patient as serum tears on the surface of the eye, we find no problem with that. So the answer to the question is, it is not a problem. If you have GVHD and you need serum tears, please, by all means, go ahead, get the drops. It will do you good, and you will feel better. The problem with serum tears is that it is a blood component therapy, so you have to treat it as such. It has to be refrigerated. You have to wash your hands before applying it. You cannot travel with it without maintaining the temperature at 4 degrees centigrade. So there are a lot of logistical issues with it, which are more of a problem than worrying about whether I have the disease and whether I can use the eye drops. It's perfectly fine.
Our next question is, once you start wearing these scleral lenses, do you have to wear them for the rest of your life? Is it ever possible for your eyes to go back producing natural tears and therefore not have to wear them?
So that's the bad news that I give my patients, and I seem sometimes pessimistic, but that's basically only because it is the present times. During our current state of knowledge, during these present times, in our current state of knowledge, we do not have a way of reviving the tear glands to start producing tears once they have been destroyed by the GVHD inflammation. So what the GVHD does is that by its immune attack on the tear producing glands, it damages them, and then fibrosis sets in. They're beyond repair. It's a scar over there. Then we cannot in today's with what I have available to me, what my knowledge base is, I don't have a way of bringing them back to life. Once the tear production is lost, it is practically lost for good. So you'll be dependent on some way of replenishing tears on the surface, whether it's artificial tears or saline or whatever. Regarding scleral lenses, they do a lot of good on the surface, and a lot of our patients initially are reluctant and they have these questions, would I be stuck with them for the rest of my life? But then they realize the good they do, the comfort they have with them, and it becomes second nature to them to wear them, and they don't think about them anymore because they just feel so good with them. They actually can see a life without them, and a lot of my patients tell me that, I just can't see myself comfortable without my scleral lenses. I wear them 18 hours a day or so. But the answer to the question, are you stuck with them for the rest of their life? No one is. And once the GVHD dies out, it burns out, there comes a point in time when we wonder about this question. And the only way to answer this question is to stop wearing them and see whether we can be comfortable, the patient can be comfortable without them. So yes, there is a time that will come when we will try to see whether you can do without the contact lenses, but they are not a burden on most of our patients. That's my experience.
This patient has found that wearing their lenses remains very comfortable and their eyes do not have pain if they leave the lenses in overnight, even for several days. They'd like to know if this is dangerous to do And are they at risk for corneal damage?
This is a very effective strategy. I do agree, and I share the same ideas regarding treating patients with severe pain and disease with contact lenses that are left overnight or for several days together. It's not a preferred way, but it is a very effective way. It comes with its risks. The risk is that there is an increased risk of infection of the cornea when we use this strategy. The risk is several folds high. If a person is putting a contact lens in the morning and taking it out at night, their risk of infection is also there, but it is not as high as if you wear the contact lens for several days without taking them out. The risk over there is, I'm saying, several folds. It's not 10%, 20% higher. It's hundreds of percent higher. So what do we do with that? Faced with that problem, we start, even if there is no infection, we start an antibiotic eye drop, a preservative-free antibiotic eye drop like moxifloxacin or Vigamox. We can start twice a day, is more than enough. So this patient would leave the contact lens in, would use the eye drops to keep it clean, rinse during the day with saline the contact lens, and use twice a day moxifloxacin antibiotic eye drop as a prophylactic agent to prevent the chance of eye infections from developing. My experience has been that when we do this, the infections are still possible, but they are uncommon. I think the patient would have to be very vigilant. If there is any new redness, irritation, foreign body sensation, pain, you would need to come in right away so that we can figure out whether we are dealing with a corneal ulcer or not and treat it appropriately early on. What you don't want is to ride out the pain with a contact lens. If it's in and it's been there for several days, you just want to brave it out or ride it out? No, absolutely not. Please don't do that. But it's a very effective strategy. We use it all the time. It's nothing to shy away from. It has to be thought of within its correct context.
Our next question is, are there side effects associated with the ocular surface disease analysis?
The side effects, meaning that when we do the ocular surface disease analysis to diagnose a patient with dry eye disease, we are putting many dyes, we are putting the filter paper and so on. Do I understand the question correctly that the procedures that we do to diagnose a patient with IGVHD, those procedures themselves have side effects? Can you clarify, Lee, if that's the intent of the question?
I think so. The question reads, I'm sorry. I got to go back to it. My apologies. Are there side effects associated with the ocular surface disease analysis? That's all it says.
Okay, so the analysis is done. I think, no, there is, we haven't had, but the only side effect is that because most of the analysis is done without using anesthesia, you will feel it. Sorry about that. I apologize to all my patients that, you probably won't like me when the examination is over. But the last test that we do is pressure check, where we put the anesthesia, and that takes the discomfort away. So yeah, the discomfort, yeah, that's the side effect. But other than that, I'm not aware of side effects. Obviously, anyone can be allergic to any chemical that we use, including the dyes that we use. So yes, every now and then we have a patient with allergy to a particular dye or a particular thing we use, but that's pretty uncommon and a rarity. But I will answer this question a different way, just to assume that that was not the intent of the question. If the intent of the question was that, are there side effects to ocular surface disease based on our analysis, then ocular surface disease if the cells on the ocular surface surface cells are unhealthy, they are diseased, they can cause a lot of discomfort, pain, because they can irritate the nerves of the cornea and on the surface of the eye. And once the nerves are irritated, they will cause pain. The surface cells, if they are diseased, they can cause vision to go down because these surface cells are unhealthy, and they cause the light not to enter the eye in its proper way, and they will diffuse, it enters in a more diffuse fashion, causing blur, and that blur can happen. So there could be the surface of the epithelium can break down, causing a ulcer or causing a non-healing epithelial defect, which can cause more problems. So if the intent was to know that can a diseased ocular surface lead to complications, the answer is you bet, yes, and you need to heal the surface.
Thank you. And Dr. Jain, do you have time to answer some more questions? We
Yes, I have all the time in the world here.
Okay, thank you. Can ocular GVHD be cured, or is it something that needs to continue to be managed?
As a general principle, my experience has been that anything that has its basis in dysregulation or disease of our immune system, be it allergies, be it asthma, be it rheumatoid arthritis, or ankylosing spondylitis, or Crohn's disease, or you name it, psoriasis, those conditions are not like infections that you give antibiotics and you kill the bacteria or the virus, and that's the end of it. These immune conditions, they don't go away. We can control them. We can control them so they're not a clinical issue anymore. They're not causing damage anymore. They're not causing symptoms or misery anymore. So we can control them. And sometimes they wax and wane so that they are active at certain points in time of their course, and then they become less active or they burn out, but they don't ever go away. So what does that have to do with GVHD? GVHD follows the same course. The first 2 years are active, and in the first 2 years, GVHD is the fire that is damaging everything. So let's have the fire concept. So that fire produces a lot of damage. And if it is not put off early or controlled early, it'll cause a lot of damage. So let's say that it brought the house down, burned the house, everything inside it. Now, after 2 years, it burns out. So there is no more fire or the fuel that fed the fire was GVHD, and fire was the damage. But that fuel is gone now. That immune dysregulation is gone now. It's burnt out, and the fire is put off. But the damage has been done. So that once the damage is done, that damage itself can cause disease. So on the surface of the eye, that's what happens. Once the GVHD burns out after 2 years or 3 years or 4 years, so yes, you can say the GVHD is probably not a factor anymore. But what did the GVHD do? It destroyed the tear gland. And once the tear gland is destroyed, it's not producing tears anymore. That becomes a disease in itself, which is called a tear deficient dry eye disease, which can cause inflammatory cycles and can sustain inflammation in of itself. So yes, the GVHD goes away, but we bought another disease. It left in its wake damage that produces entities in of its, which are basically disease entities in of themselves. So you can say that GVHD burns out, but leaves behind in its wake damage that causes dryness, dry eye disease, and that has to be treated. So some treatments will have to continue long after GVHD is gone. We can't escape that. Until one day somebody figures out how to rejuvenate the lacrimal gland, revive them, tissue engineering or whatever. People are working in that direction. We'll get there someday.
Thank you. Our next question is about allergy conjunctivitis, white stringy mucus. Is this also considered possible ocular GVHD?
This is a question that interests me a lot because I got very big NIH grants on this, and we discovered some medications and had some clinical trials based on this. I used to think the same way when I was doing my residency and my training as most people do, that the whitish things that we see coming out of the eye are mucus, until we realized that that's not all they are. They're not all mucus. This is an inflammatory mess. It comprises of inflammatory cells. It comprises of many inflammatory proteins, and yes, some mucus. So when you see these whitish things coming out, it is not don't think it is just benign mucus. Think of it as an inflammatory mess that's coming out. Think of it as a sign that is telling you that there is inflammation going on. The fuel that is feeding the inflammation might be allergic reaction, fine, or it might be immune issue, which is GVHD. Whatever the fuel that is feeding that inflammation is, that could be different. But the white stuff that is coming out is the product of inflammation. And it tells you that you need to control this by anti-inflammatory strategies. Could be steroids, could be other non-steroidal anti-inflammatory agents, could be whatever strategies are taken. But we need to control the inflammation. So that mucus that is coming out is indicative of an inflammatory problem that is either due to allergies or due to GVHD or due to an inflammatory attack on the eye due to other conditions like rheumatoid arthritis or lupus or reactions to drugs like Stevens-Johnson syndrome, which is an extremely bad reaction to drugs, or skin diseases that can cause problems on the surface of the eye, cicatricial pemphigoid, a lot of these conditions. So beware of mucus. Go seek treatment when you see this, especially if the eye is red also. So I'll stop over there. I hope I answered the question to satisfaction.
Thank you so much. Our next question is, if somebody already has severe ocular GVHD for years, would there be much success with starting tacrolimus eye drops at some point?
So tacrolimus is an anti-inflammatory eye drop. So I've been using the term anti-inflammatory eye drop. So the question really is, does tacrolimus has any great advantages over other anti-inflammatory eye drops? Or is it one of the members of a family called anti-inflammatory eye drops to be used when we deem it necessary or fit to be used? I think tacrolimus should be treated as a tool, an option in one of the several options that are available to us to treat dry eye disease or to treat IGVHD. And those include steroid eye drops like methylprednisone or predforte and so on. That includes cyclosporin eye drops. That includes, we use pooled human immune globulin eye drops. That also includes tacrolimus eye drops. Can we use it at some point in the treatment? I think we can. The problem is that tacrolimus will have to be compounded in a pharmacy. You cannot get it prescription in a regular pharmacy. That's one problem, that you need a compounding pharmacy to formulate it. And then can it be used? Yes. But the context is important. Steroids, I feel, are more easier to use and they work very well and would be my first choice. But some patients, they develop pressure rise, their eye pressure increases with steroids. Then what do I do? If they develop, if I use steroid eye drops, which are very effective, but when I use the steroid eye drops, the pressure in the eyes go up. I cannot have that situation now because that will cause glaucoma and blindness can result from that. So I have to stop the steroids. I cannot use the steroids now. In that situation, tacrolimus becomes a very viable and a very good player and a good option because now I can use tacrolimus eye drops. So it's no big deal. If a person cannot use steroids, fine, I can use tacrolimus now. So this all has to be placed in the right clinical context. Do I feel that tacrolimus has a lot of advantages over other anti-inflammatory drops like steroids? No, I don't think so. But do I feel that tacrolimus is a very good anti-inflammatory eye drop to be used in the correct clinical context? The answer is yes, very much so.
Can laser treatment help ocular GVHD?
Laser treatment it depends on. I think by this we mean IPL or intense pulsed light treatment is the kind of laser that we may be thinking of, because that's the one we can use to treat some forms of oil gland disease, and it can help. But in general, laser treatments are more for retina and for glaucoma than for surface diseases. So laser treatments are not traditionally used to treat surface diseases like IGVHD, with the limited exception. I'm putting IPL or intense pulse light treatment into the laser category just because that might be the way we may be thinking about lasers. Other than that, I think the role is very limited or none.
Sorry, thank you. Our next question is, hang on 1 minute. Do you recommend that all patients who have been diagnosed with chronic GVHD get a baseline? It says, I have only one seeing eye.
Absolutely. I think this is, if there is one thing that organizations such as AAMDS and other BMT Infonet and other people, and all of you people who are listening on this call, if there is one thing you can do to change the way people think about this disease and do favors to people who are going to get bone marrow transplant in future, this is it. Tell them that do not think of this as just another dry eye. And it is very important to form a baseline before bone marrow transplant to see where the eye starts from, what the meibomian glands look like, what the tear production looks like, what the surface looks like. A pre-transplant exam is a must and should happen. And in fact, I was on the committee on NIH, which has just come out with a paper which lays out the plans for the future. And we have made a very strong pitch over there to emphasize this very important point that in this condition, we need a pre-transplant baseline examination, and we need a examination every 3 months after transplant for adequately controlling and helping patients who get bone marrow transplant so they don't get a very severe form of IGVHD that robs them of tear production, gives them a dry, irritated, red, inflamed eye that reduces their quality of life to such an extent that they cannot now go out, and light sensitivity is very, it bothers them, takes over their life. I think that is something that is avoidable. I think if it happens, if it happens, it happens because we're not doing a good job. I think there is no excuse for this to happen. It is very much preventable. And I think everybody should play their part. Like I said, everyone listening on this call, should they play their part in raising awareness with everyone there is who deals with this condition, that read these papers that NIH is putting out We're not talking just because I feel this way. It is written out there, it's published out there. We have the backing of NIH on this. We are telling the world this is a very important thing to do. Pre-transplant examination, every 3-month examination thereafter. You don't have to wait to treat yourself based on, well, it is not very symptomatic right now, just irritation, artificial tears are enough. No, they're not enough. You have to go to a eye doctor to get the exam done to see what's going on, how much the inflammation is, and get appropriately treated aggressively early on, because there is a window of opportunity. There is a very small window of opportunity where we can save the structures of the eye and save the function of the eye. Once it's lost forever. So why would you lose something forever if you can save it?
Next question is, have you had any success with platelet-rich plasma?
We use it in some patients, and some patients who love it for some reason. I started using platelet-rich plasma or PRGF with great expectations and hope. We were using serum tears before that. It makes logical sense, it makes biological sense, it makes scientific sense. It makes sense every which way, and that's why we started doing it. It's more expensive than serum tears, much more expensive than serum tears. My experience has been that for most patients, there is not much difference whether you use preservative-free serum tears, 50% eye drops, or you use PRGF or PRP. I'm saying for most patients, probably 80% patients. There are very few patients who come and say that there is some difference. And a lot of them actually are using serum tears with PRGF. Because PRGF is more expensive and you get less quantity, they end up using every day 3 or 4 drops of serum tears and 1 or 2 drops of PRGF in between. I'm not going to say over here that it is a bad idea or there is not good data out there and that from other institutions or from other places and from other physicians who would tell you that PRGF has significant advantages over serum tears. I would agree with them. I am telling you what I have seen with our big practice in IGVHD and in autoimmune dry eye disease, Sjogren's syndrome, Stevens-Johnson's, and so on. This has been my experience that for most patients, it is not a significant advantage over serum tears. It's worth trying, yes, you bet. But if it doesn't do anything more than serum tears, I would say switch to serum tears back.
Our next question is, if artificial tears taken 4 to 5 times per day seem to be working, is there an expectation that no other treatments will be necessary?
It's a question that I think you should place it in context. And if the context is dry eye disease, garden variety dry eye disease, the strategy is okay. But if the context is IGVHD, which is an inflammatory attack on the surface of the eye with a fuel of immune dysregulation that is being channeled every single moment by the GVHD process, and every single moment the inflammatory attack is happening on the surface of the eye, then what are we doing with just artificial tears alone? We may be making a mistake by saying or believing that just because artificial tears seem to be soothing and the patient is feeling a little better because of that soothing, that the attack has subsided. That's a mistake. So in this context, in this condition, I think I would suggest a full evaluation to gauge the extent of inflammation, extent of surface disease, and figure out how much anti-inflammatory therapy you need, whether or not artificial tears are making you feel okay. The other thing that I want you to keep in mind also And it's a very important point, that a lot of patients, a lot of these diseases, they destroy the nerves inside the cornea. So you're not going to feel the pain that you should be feeling. And if you don't feel the pain, you may just think that artificial tears are enough because you've increased the moisture and you feel good about it. Well, maybe you're not feeling all the bad that you should feel because your nerves have been damaged by the inflammatory and immune process or those cells. So you can't assume that. And I would strongly caution against assuming that. I don't think it's a good idea. I'm giving a long answer because I think this deserves a long answer. I definitely, in the strongest of the terms, do not feel it's a good idea to start with artificial tears and stick with them. If your eyes have become symptomatic, they are irritated, red, or you started to develop symptoms, and artificial tears, you start using it thinking that that's the cure or that's the treatment for your problem that is the symptoms after bone marrow transplant, it's a huge mistake. You need this is a much bigger thing that is happening, and you need to get appropriately and aggressively treated, not just artificial tears.
For this patient, their GVHD originally manifested with the skin and was treated with tacro, prednisone, and Jakafi. Now, this patient has minor eye dryness and drainage. They're now on a small dose of the Jakafi only. Will Jakafi be beneficial for their eyes?
Jakafi is generally I like it. It's a good medication for the eye. One of the few medications that I asked our bone marrow transplant colleagues to start on my patients when we are struggling to control the eye disease. In addition to steroids. Steroids, of course, if you give, control everything, but Jakafi is a good drug. It can have beneficial effects on the eye. Doesn't mean that's the only thing that you need to that you will need to control eye GVHD. It's a help, and it's a good help. But even in the presence of Jakafi, you might need other treatments on the surface of the eye. So I would think of Jakafi as a friend, a drug friend that is extending a helping hand to the eye GVHD treatment. But I would not think of it as the only thing that you need to treat eye GVHD.
Thank you. Are patients that have had LASIX before transplant subject to having more complications with ocular GVHD?
Well, in general, LASIK compromises certain, in some patients, not all, in some patients, LASIK compromises the structures of the cornea. And the one structure that it compromises most is the nerves within the cornea. When we do LASIK, we have to cut a flap with a laser or a blade in the cornea so that that flap that is made, it cuts the nerves. And those nerves, most often, they don't regenerate, or if they regenerate, they do not regenerate in the normal fashion. And that's the problem with LASIK. So assume as a patient who has had LASIK and in whom the nerves have been destroyed. In such a patient, if IGVHD sets in, we have lost a good defense mechanism and a healthy surface of the eye. And maybe these patients are going to develop more severe disease than surface disease than if the patient did not have LASIK. That doesn't mean all patients with LASIK who develop IGVHD are in trouble. That means that LASIK has the potential of making life a little bit more difficult for these patients than if they had not had LASIK.
Do vitamins such as Ocuvite help patients with ocular GVHD?
They're not, vitamins are fine. I mean, even this, they're controversial even in dry eye disease, as you all know. There have been clinical trials that have been done for omega-3 supplementation that have not proven that they can help. Ocuvite preservation type of vitamins, they have been tried in clinical trials for macular degeneration, and they do very good for macular degeneration. They prevent, they serve the patients who have early macular degeneration well by prolonging the time it takes for severe disease to set in. So if I see a patient with drusen, like a yellow spots on the retina, unrelated to GVHD, Ocuvite type of vitamins, Ocuvite preservation, it's called, or AREDS formula, they are very helpful. I would give them. On the surface, for the surface of the eye, Ocuvite type of vitamins, in my view, are not as helpful as they are in macular degeneration, or I don't give them because I don't think they help as much. But am I opposed to people taking Ocuvite type of vitamins? Probably not, because if vitamins taken in recommended doses, if they're not doing any harm, well, I can accept that position. They're not doing any harm, but I don't sell the benefit to the patient with them. The type of vitamins that can help and still are controversial are omega-3 supplements, flaxseed oil, those kind of things I think may work better for ocular GVHD also than Ocuvite type of vitamins.
Thank you. And we had 3 questions that were all centered around the same topic. And it's about, how does a patient find an ocular GVHD specialist? Is there some type of association that you can find a physician? And the other is, if you're not working with a ocular GVHD specialist, how does a patient help them understand what their condition is? What type of suggestions do you have that would be helpful?
So the answer to the first question, there are national level organizations who are trying to create a database of IGVHD doctors in the country, in US. And it is called BMT, B as in boy, MT, like bone marrow transplant, BMT Infonet. So if you Google BMT Infonet, it's a nonprofit organization. I have had the opportunity and the honor to speak with them and their audience in the past, and they are doing they are building this database, and I think it's a searchable database that you can go on their website and put your location, and physicians who have a special interest in IGVHD, their names pop up. That's the one that comes to my mind, and that's the one I would suggest. But I think you should not be shy in reaching out to people that treat IGVHD. I mean, clearly this is our passion. This is what we do at UIC, and feel free to reach out to any of our team members for recommendation. We may not be able to help you in outside of the Chicagoland area, or you may not be able to come to us for evaluations, but we can certainly give you recommendations. So I think if the worst thing you could do is to not ask and not reach out. Don't do that, please. Go to BMT Infonet, look at who's there, and if you don't have any answers, reach out to us. We may not have the bandwidth to answer all questions the moment we get them or give you replies, but believe me, we'll reach out to you with something in time. So that's one. The second question was, how do you tell people who don't have the opportunity to get their care from physicians who specialize in ocular GVHD? What can you do? I think and this is one of those situations where you've been through a lot already. You've had, you've had cancers. You've had treatments for that and failed them, and then you've had bone marrow transplants, and then you had all these medications given to you and hope, and you've been through a lot. And I think it is the onus, or I would say, I think that's enough motivation for you to be your own advocate. Or your families, and families become advocates. And part of being an advocate is increasing your knowledge base, increasing more understanding of the condition, listening to these webinars, making an understanding of the condition, and then transmitting that to your physicians. Oftentimes, people don't do that because of hesitation or coming across as, well, maybe they don't have confidence in the physicians they're talking to, but don't do that. I think it is important for you to develop a basic understanding of the condition. One of the most fundamental basic understanding of the condition is that this should not be thought of as or treated of as just another dry eye. Can you just remember that mantra? This is not just another dry eye. Neither should it be thought of as, nor should it be treated as just another dry eye. What ocular GVHD or IGVHD is, it is a severe inflammation. It is an immune attack, just like a cytokine attack that has killed so many people in COVID-19. What is that? This is an immune dysregulation. It's the same kind of situation. This is an immune attack on the surface of the eye that is producing a nasty inflammation, and this needs to be treated aggressively and with the thought process of an immune injury inflammatory condition, just like Steven Johnson syndrome or ocular cicatricial pemphigoid or other immune conditions that are there. So I think you can. You have to be your own advocate. This is not a disease that affects millions of people. IGVHD is an orphan condition, meaning that there are less than 200,000 patients in this country. Now, if each one of you think that somebody else is going to educate the world about it, it's not going to happen. Every one of you needs to be an advocate for the spreading of awareness of treatments, papers. You could, the NIH papers or whatever it is, or whichever way you can. I think it is so important for you to talk to your physicians, but talk to them from a position of knowledge, not a position of ignorance.
Thank you so much, Dr. Jain, for spending your time with us today and staying over and answering all of these fabulous questions. And just wanted to let everyone know I did share the contact information for BMT InfoNet. They're great friends of ours here at the foundation, and they can be a great help to finding, as Dr. Jain said, an ocular GVHD specialist that would be near you. So thank you again for joining us today, to everyone. And if you'd like to watch this webinar again.
Just, can I, Lee, can I just add one thing?
Sure.
That we have the email, one of my colleagues just reminded me that I said that you could reach us without telling them how. So it's very simple. O as in ocular, OGVHD at uic.edu.
And if anyone would like that, just send me an email and I'm happy to email that to you as well. Thank you, Jacob, for putting that in the chat to you as well. Thank you, Jacob, for putting that in the chat for everyone. Thank you again for joining us. And if you'd like to watch this webinar again at a later time, it is going to be available on our website within 2 to 3 business days. If you have any additional questions, please feel free to reach out to us. You can send us an email to help@aamds.org. You can call our helpline at 800-747-2820, or you can submit your question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to help you and your family, as we've done for the past 38 years. This concludes our program. Thank you again so much, Dr. Jain, for sharing your time and staying over today. Thank you.
Thank you. It's been a pleasure.
Take care now.